Hello, everyone, and good evening, good afternoon, from wherever you're joining us from. My name is Anne Juguna, and thank you so much for joining this particular webinar for the Girl Generation Program. And thank you so much for joining us. We are really glad to have you on board. And as planned, we had planned to start at 4:30, so we will just be able to begin at this time. I would like to let you all know that we are interpreting the webinar in both French, Amharic, and sign languages. Please click the globe sign below the screen so you can select a language of preference. And also, we want to kindly let you know that this webinar is being recorded for sharing externally for those who will not be able to join us. We will also be taking questions and comments at the end of the webinar and also in between the webinar. So type them on the chat box and we'll be able to take in the questions and the comments at some point. And also a reminder to all of us as we engage in this discussion and share our thoughts, let's be mindful of the sensitive nature of FGMC and all forms of gender-based violence and its impact on survivors. So we really want to encourage that this space be an open dialogue, all have understanding, empathy, and also create a supportive environment for survivors who want to share their personal experiences. And at this point, allow me to welcome our moderator, Dr. Jacinta Muteshi, the team leader for the Girl Generation Program, Support to the Africa-led movement to end FGM. Dr. Jacinta is a renowned globally expert in gender equality, women's rights, reproductive health, and constitutional processes, with experience as a researcher, program director, and also advisor. Jacinta has led large international multi-year research evaluation and advocacy programs and received her PhD in education from the University of Toronto. Welcome, Dr. Jacinta, to this webinar. Thank you.
Thank you very much, Anne. Hope everybody can hear me. So hello to everyone, and thank you for joining us as we discuss the vital role of the healthcare sector in responding to and preventing FGMC. Allow me to share briefly about our program and why this discussion is timely. The Girl Generation Support to the Africa-led movement to end FGM, also known as TGG-ALM, is a consortium partner led by Options Consultancy Services and includes MREF Health Africa, ActionAid, Orchid Project, University of Portsmouth, and the Africa Coordination for the Abandonment of FGMC, ARCAV. We also work very closely with Population Council's Data Hub. TGG-ALM is being implemented in Kenya, Ethiopia, Somaliland, and Senegal, with a broader vision of a world where girls and women can exercise their power and rights, have expanded choice and agency, and be free from all forms of violence. Globally, we're seeing an increase in medicalization of FGMC. Yet we all know that FGMC has no known medical benefits and remains a violation of the human rights of girls and women. Our consortium partner, ARCAV, has developed an End FGMC training curriculum using the most current evidence and best practices available from the Ministry of Health in Kenya and the World Health Organization. In line with this year's theme for 16 Days of Activism, which is Invest to Prevent, ARCAV's curriculum has been used to deliver a standardized End FGMC training content to health professionals that interface with women and girls at risk of FGMC and those who present at service points with FGMC-related complications. This webinar will allow us to understand how FGMC is also a public health concern and why health practitioners should be equipped to prevent and respond to FGMC complications. We will also learn more about how ARCAV and the World Health Organization, WHO, are engaging health practitioners in ending FGMC. and have an opportunity to listen to practitioners and survivors on successes, challenges, and what more needs to be done to end medicalization of FGMC. So with this background, allow me to invite Madam Bernadette Luluju. She's the Chief Executive Officer of the Kenya Anti-FGM Board to give us a keynote address. Madam Luluju is not new to many of us, as she has been at the forefront of end FGM campaigns in Kenya and in the region. Madam Luluju has served in different capacities in the field of girls and women's empowerment for more than 15 years, and through her efforts has been able to save many girls from FGM and forced marriages. Being a survivor of FGM, she feels that it is possible for every girl in the world to be safe as long as communities are fully engaged in the process of bringing the cut to an end. So a very welcome to you, Madam Bernadette Luluju.
Good afternoon, everyone. All protocols observed. Thank you very much, Jacinta, and thank you everyone who has prepared this meeting. I'm going to give my keynote address. All protocols observed, ladies and gentlemen. It is yet again another great opportunity for all of us to focus on the vital role of healthcare providers in the prevention and response to FGMC. On the other hand, it's unfortunate that today we are discussing a public health issue that should not at all be associated with any responsible healthcare provider, cognizance of the fact that they are bound by the medical health principle of do no harm. But because the challenge of medicalization of FGMC is with us, we must involve health professionals to find sustainable solution to its prevention and response. I therefore want to compliment the girl generation for the well thought out idea of having this virtual meeting at this moment when the international community is observing the 16 days of activism against gender-based violence. FGMC being the worst form of violence against women and girls, we need more urgent and targeted to it. Indeed, the health sector has an important role to play, not only in ensuring the highest quality healthcare for girls and women living with FGMC, but also in preventing it from happening. FGMC is a social behavioral norm that, despite increasing the risk of negative effects on the health and well-being of girls and women, is often difficult for healthcare providers to discuss. However, healthcare providers are in a unique position to influence and change the attitudes of their patients regarding FGM, which is a key step towards preventing new cases of the practice among communities. Healthcare providers also have a role to play in advocacy against FGMC, creating awareness to the public on the health consequences of FGMC, researching and accurately documenting on the new indicators ranging from prevalence, attitude change, the cost of burden, and best practices. Ladies and gentlemen, the Anti-FGM Board is a state agency in Kenya established in 2014 after the enactment of the Prohibition of FGM Act 2011. The board therefore derived its mandate from the Act. The board's vision is to have a society free from female genital mutilation. The board designs and implements its strategic interventions to end FGMC in Kenya from evidence-based key findings, recommendations, and indicators from the Kenya Demographic and Health Survey, which is generated after every 5 years. The primary objective of the KDHS is to provide up-to-date demographic health and nutrition indicators to guide the planning, implementation, monitoring, and evaluation of population and health-related programs at the national and county levels. According to the KDHS, the prevalence of FGM in Kenya has been on the steady decline. Statistics from KDHS 2022 indicate the prevalence of FGM in Kenya was 15%. In 1998, the prevalence was 38%. 2003, 32%, 2008 to 2009, 27%, 2014, 21%, and 2022, 15%. Further analysis of KDHS 2022 indicates that the prevalence of FGM generally increased with age. We can see that women between the age of 15 to 19 are at 19%, while the upper age group, that is age of 45 to 49, are at 23%. This shows that there is a positive indicator that the young people are informed of the consequences of FGM, leading to the low uptake of FGM within the young cohort. And that also means that more parents are aware of the negative effects of FGM, not exposing to their children to FGM. However, it is disturbing to learn from the survey that counties with the highest knowledge of FGM are the ones with the highest prevalence of FGM. Notably, Wajir and Kisii County, which have been classified as FGM hotspot counties, have 100% knowledge of FGM among women. Poverty and low educational levels are major contributors to the perpetuation of FGM in Kenya. The 2022 KDHS indicates that the knowledge regarding FGM to women in the lower health quartile is 93.2%, compared to 98.6% in the highest wealth quartile, while the knowledge on FGM is 92.4% to women with no education, compared to 99.3% to women with more than secondary education. Further, 98% of women living in urban areas have knowledge about FGM, compared to 96.2% of women living in rural areas. The KDHS 2022 also indicates that 56.3% of women with no education are cut, compared to 5.9% with more than secondary education. Ladies and gentlemen, from the stated indicators from KDHS 2022, it is important to note the following. Education for girls is a long-lasting and sustainable intervention to eradicate FGMC. Women and girls' economic empowerment is key in addressing the social, cultural, and economic challenges that have and continue to hinder the emancipation of women from poverty and disempowerment. The uptake of End FGM campaign is taking root among the young people as compared to the older persons, and subsequently, this is the generation that will end FGMC. Therefore, there is need to drive more youth-led and youth-friendly interventions in the End FGM campaign. The average knowledge about FGM in Kenya is over 90%. Therefore, more creative interventions that will go beyond awareness creation are needed. There is need for enhanced coordination, partnership, collaborations, and linkages. More resources are needed to reach out to communities, especially those living in the rural areas, the marginalized, and the hard-to-reach areas. Community-led and people participation strategies are needed for ownership and sustainability of strategies and interventions. Let communities own the process. Enforcement of the law must be a key priority to all duty bearers, civil societies, champions, and role models. Movement building should be enhanced, especially in regard to survivors of FGM. Survivors of FGM to be on the forefront, to publicly share their struggles with the burden of FGM and the need to protect girls. Strategies to be more targeted to community specific and be those that will yield more outcomes, irrespective of time and resources required. Accurately and timely data is required to inform decision-making, action planning, policy derivation, and programming. The Kenyan experience shows that political goodwill is very significant to end FGM. Notably, the presidential directive to end FGM by 2022 by the former retired president, His Excellency Uhuru Kenyatta, and a lot of pronouncements that have been done by our president, His Excellency President Ruto. He has been able to really push for this agenda even during the Kenya Kwanza time, even increasing funding for the anti-FGM board. The directive that was brought on board really helped us to really push the agenda of ending FGM, and we have seen that work, and we've had multi-sectoral approaches now in the End FGM campaign. And ladies and gentlemen, the issue of medicalization, we cannot end emerging trends on FGM in isolation. We must forge partnerships to leverage on economies of scale, expertise, resource mobilization, and comparative advantage of various implementing partners. It is on this basis that the anti-FGM board has partnered with various institutions such as universities, CAF, Kenya National Bureau of Statistics, ministries, departments, agencies, and counties to come emerging trends. To this end, the Ministry of Health in Kenya has made immense contribution in eradicating medicalization of FGM, reporting and handling FGM complications. Some of the documents the ministry has developed include FGM prevention and management of health complications for healthcare workers, and person-centered communication for FGM in healthcare settings. The Ministry of Health has also reviewed data capturing tools to include FGM. Policy statements for healthcare workers on medicalization of FGM have been issued to counties. On cross-border FGM, Kenya, alongside Tanzania, Uganda, Ethiopia, and Somalia, have developed a cross-border action plan to end cross-border FGM. Constantly, Kenya has engaged duty bearers, civil societies, and communities along the borders. the vision of the board and the strategic direction to end FGM in Kenya. The vision of Anti-FGM Board Kenya is a society free from female genital mutilation. The strategic direction of the Kenyan government has been captured in the manifesto of the current government under the Women Agenda that commits to increase funding to the Anti-FGM Board and enhance implementation of the Prohibition of FGM Act 2011. The board has also formulated its strategic objectives for the next 5 years with a view of eradicating FGM. This includes to strengthen the capacity of resource persons, raise public awareness, and engage in empowerment initiatives to effectively prevent and respond to FGM. To strengthen legal and policy reforms in FGM prevention and response, to enhance coordination, forge effective partnerships, and promote collaboration for a unified fight against FGM. To address emerging trends in FGM, including cross-border practices, medicalized FGM, lowering the age of cutting, adult women cutting, and sooner FGM. To ensure adequate and sustainable resources availability for FGM elimination. To strengthen evidence-based decision-making for FGM prevention and response. To enhance institutional capacity and effectiveness for the anti-FGM board's operations. Ladies and gentlemen, as I conclude, I want to thank ACA for developing an evidence-based training curriculum for health professionals. It is my expectation that the manual will equip health professionals with the requisite skills and knowledge to handle and respond to FGMC. I also thank the Girl Generation for their strategic position, immense contribution, and stewardship in the campaign against FGM. In this regard, my clarion call to everyone listening is pamoja tukomeshe ukeketaji, which means in solidarity, we end FGM. Thank you and God bless you. Thank you very much.
Thank you very much, Madam Bernadette. We very much appreciate that keynote. And I think once again, what you have done is reiterate for everyone the importance of integrating and working with the healthcare sector with regards to our efforts to end FGM. But you've also put on the table for us to keep at the forefront in terms of the kinds of interventions we undertake, that they're surely youth-led, community-led, as well as survivor-led. You're also reminding us that our interventions will need to be more creative, and to be learning from what we are monitoring from the ground and having that inform how we continue to seek resources and how we continue to respond and support efforts to end FGM. So thank you very much for those comments. Ladies and gentlemen, is now actually move into the panel discussion. And I want to invite our panelists as we get into our panel discussions. So our first panelist is Dr. Mona Abdullahi, who serves in the emergency department of Boroma Regional Hospital in Somaliland. She's also the head of Ahmad University's Assessment and Examinations Committee in the Department of Medicine and Surgery. She's also a lecturer for undergraduate medical students. Her areas of interest include research, women and children's health rights, and community health. So, Dr. Muna, my first question to you is, what are the current trends observed in Somaliland regarding the campaign to end FGMC?
Thank you so much. Good afternoon, everyone. I think in Somaliland, the trends towards ending FGM, there is a lot of awareness of it more that now it's an issue, because previously we only used to focus on ending some type of an FGM, but not the other type. But the trend lately is towards ending it completely. So when it comes to Somaliland context, there's cultural and there's also religious involvements in here. So to end FGM actually requires the involvement of not only the politicians, healthcare workers, communities, but a big factor here is the religious leaders. So the trends in the past few years were to involve the religious leaders in open discussions, make them understand, the harmful practices, and slowly get the community to a point where they agree this can be done, this cannot be done, so the policies can be drafted by the government once everyone agrees. So the trend is now towards focusing on the culture and the religion basis. So I think that answers my question now. I mean, not to start even at the healthcare levels, because there's also, when it comes to statistics, the medicalization of FGM is rising here, especially in the past few years. So I think we are facing the same issues as Kenya, but we have different contexts here to address. So UNFPA, UNICEF are heavily working on these issues on the ground, the discussions and awarenesses. Yeah.
So maybe, Dr. Muna, if you could follow through with that a little more. How do healthcare professionals contribute to advocacy levels aimed at ending FGMC and addressing health complications arising from FGMC in Somaliland?
That's a great question. I mean, as a healthcare, I think at the back of our heads, even back in medical schools, FGM is never a part of the curriculum of the universities in our country. So, with that being said, it is never seen as an issue to be studied, to be addressed. So, even when you graduate from medical schools in this country and you see patients, the first time you see an FGM victim, healthcare workers feel like they're not equipped enough, to face that, deal with the complications, and forget about awarenesses and other levels. So I think as a healthcare worker, once you graduate, I mean, you educate yourself, but then it becomes a separate entity than other issues. Like if you say this patient has hypertension, everyone will see it as an issue. But if you say it's an FGM, it's like, oh, it's an FGM. So I think healthcare workers are not a big part of the awareness in ending FGM. Maybe some who works for NGOs, for the government, but as a whole, there is a huge gap in this country in their participation in ending this huge issue.
All right, Muna, thank you very, very much. So if I might move to our second panelist, Elishua Ngina, a final year medical student at the University of Nairobi, who has a passion for the field of obstetrics and gynecology. So in addition to her academic pursuits, she's deeply committed to advancing women's health, specifically in the areas of sexual and reproductive health. So Elishua, my first question to you is, as a pre-service medical student, what were the eye-opening moments when interacting with ARCAV-led training on FGMC prevention and response?
Hi, good evening, everybody. Yes, thank you so much for the introduction, Madam Jacinta. I'm so happy to be here as part of this panel, and I'm so happy to see all of you. Thank you, Girl Generation, and all the other partners for this amazing program. So let me first answer your question by telling you how I came to know about ACAF. I was just a fifth-year medical student with very little, and I'm embarrassed to admit it, but almost no knowledge about the practice of FGM, because this practice of FGM, as Dr. Muna said, was never taught in our syllabus. It was never part of our curriculum, apart from just mentioning it, that it exists or such a practice exists. We were never taught about it. All we knew were very superficial details about FGM. There was no medical discussion about it, or that topic itself was not given any importance as it deserved. Until one day I came across a patient who had undergone FGM and had come to our hospital to manage the complications that she was suffering because of she had undergone FGM. And that's when it caught my attention. And that was the first time I had seen a victim of FGM. And I was not aware of the medical complications that were associated with FGMC. And I even didn't know the seriousness of this practice until one day my friend in my senior class told me that she attended an FGM seminar by ACAF. And she told me, Gina, why don't you join it? You would love it, because she knew I'm an advocate for sexual and reproductive health. And she was right. I actually loved the training by ACAF. It was a 2-day seminar held at the University of Nairobi by ACAF and the Department of Obstetrics and Gynecology. And it was a really eye-opening experience for me. ACAF has made a remarkable and a pioneering stride by actually introducing the subject of FGM to us medical students, and it's never been done before. And it was one of a kind because it was an extremely insightful session that didn't just brush upon the surface. They went in depth in everything. They talked about many topics about such as the FGM hotspots, where they are in Kenya, where they are around the world. They talked about the types of FGM. They talked about the medical side effects, both the immediate side effects and the links. They talked about the psychological trauma. They talked about the sexual dysfunction that follows the girl after. They've talked about the legal aspects as well as the trends of medicalization of FGM, like you said. It was not just it wasn't just a streamlined session. It was a multidisciplinary approach. It was a multidimensional approach, sorry. And it talked about so many things, the drivers, the cultural practices, the religious aspects associated with it. It was everything. They talked about everything. And hearing all of these atrocities that were being done to girls around the world and in Kenya really made me angry, but more, it gave me it made me overcome with a sense of responsibility to be part of the change, to be part of the solution, and to change the harmful norm. And I know when I go out into the field, I will make a difference and make FGM a thing of the past. Yes.
Thank you. Thank you very, very much. So my second follow-up question to that is, what more needs to be done, in your view, to ensure that both the pre-service health trainees, such as yourselves, and in-service health professionals here to do no harm and advocate for an end to FGMC?
Yes, thank you very much for your question. And this is a very crucial topic to discuss because we're seeing a rising number of medicalization of FGM, and that is something we need to tackle immediately. So, because we have a lot of doctors and a lot of ex-medical practitioners doing FGM or practicing FGM in secret in their clinics, and we have seen a lot of this, and we have heard real-life stories of this happening. And to stop that, I believe at our level, education is paramount. We need to start with educating medical students and pre-service people in the beginning. And it's very important to do it through seminars like ACAF is doing. You can have training sessions, seminars to really give pre-service people, pre-service students, a deeper insight on what FGM is. What are the physical side effects? What are the psychological side effects? What are the sexual problems that a woman faces after this? They also need, as doctors or pre-doctors, pre-interns, we need to be taught about the legal and the ethical aspects of this because as doctors, we need to be highly ethical in our practice and everything we do. If we teach them about ethics young enough, they will not go out into the field and engage in unethical practices just because they get more money out of it. So in short, I believe that FGM should be incorporated into our curriculums. And when they go out into the field as pre-service interns, you should talk to the community, talk to people, and engage in community dialogue. And if it's not community, talk to your friends. Talk to your family. Talk to you when you go back home to your village. Talk to people in your extended family that this is wrong. This is our side effect. No matter how big or small, you will make a difference. And eventually you will end up saving a girl's life.
Yes.
And most importantly, as people, as doctors, we're supposed to do no harm. So we should all work together to end FGM. Thank you.
Thank you very much for those comments, Elishua. Just to make a brief comment here, because both Dr. Mona and yourself, by your presentations, you're highlighting for all of us that there's really been no effort with regards to medical curriculum to ensure that pre-service and in-service health providers will have the knowledge and skill needed. So, and because you are two different countries, what that highlights is that it's common, right? That it's not unique to Kenya, it's not unique to Somaliland, and this might be the case in many countries actually. So hearing you both share those experiences is really critical. One already a practicing doctor and one hoping to enter that medical field. So that's a really valuable contribution. And the other very valuable contribution about what you've shared, both of you, is that it isn't only going to be about addressing physical complications, but it's also going to be about being attentive to the psychological well-being of survivors, because those who come in front of you are the survivors, but there are also those who do not survive. So thank you very much for those comments, very helpful. So if I may move to the next speaker. The next speaker I now want to invite is Rosalind Buyo, a dedicated nursing officer and a survivor of FGM, who stands at the forefront of change in Isiolo. Isiolo is in Kenya. And as the founder of Waso Hope community-based organization, Rosalind has earned accolades for her unwavering commitment to women and girls' rights, including Peace Champion, having been recognized by the Interreligious Council of Kenya for peace-building initiatives in Isiolo County, and has received an award from the Anti-FGM Board of Kenya for her outstanding contributions to end FGM, as well as championing women's rights in Isiolo County. So a very warm welcome to you, Rosalind. So tell us, Rosalind, why do women and girls who have undergone FGMC sometimes hesitate to seek medical attention when confronted with health issues? That's my first question to you, Rosalind. So let me give the floor now just for 5 minutes to research by Koval. So we've listened to Dr. Mona, we've listened to Elishua, we didn't get a chance to listen to Rosalind, but I would like to invite Frida Nyaga, who's the Acting Executive Director for Coalition on Violence Against Women, Koval, which is a national nonprofit women's rights organization that was established in 1995 to respond to the silence of the Kenyan society in addressing violence against women and girls. Koval recently did a study on medicalization of FGMC among the Maasai community in Kenya. So welcome, Farida. Very briefly, share with us key highlights from your recent research.
Thank you so much, Dr. Jacinta. Well, as you have mentioned, we are a non-governmental organization. We are currently implementing projects around 4 thematic areas. One is access to justice, access to comprehensive sexual reproductive health rights and sexual and gender-based violence services, women's leadership development, women's economic empowerment, institutional development, and institutional development. If I can go directly to our study, is that we did a study, and we are currently funded by the TGG ALM project to implement a project called IREPU, which is MA for the Arise to end FGMC. So we did a study on medicalization of female genital mutilation in Maasai communities, and some of the objectives for the research were to understand the magnitude of medicalized FGMC as a safer form of FGM in Narok County, and safer in quotes, and then also to understand the health, social, and the legal factors underpinning medicalization of FGM, and also to understand, to determine the role of health professionals in aiding medicalized FGM. So in terms of the methods we used mixed methods, including a desk review, qualitative methods, quantitative, a data analysis, and then we also had a dissemination workshop. In terms of the performer of FGM, now here it's general performer of FGM, we find that the traditional cutters are leading with around 70%, and then also the healthcare workers are coming in second with 21%, and then also the traditional birth attendants are also coming in third with around 6%. To continue with that, still on the reported type of FGM among women aged 15 to 49 years, just to mention is that the Kisasa type of FGM is also more of a medicalized FGM, and we find that it's also gaining momentum in Narok County, whereby 38% reported to have gone through Kisasa type of FGM. And then in terms of the performer of FGM on daughters aged 0 to 14 years, I just want to highlight that as you can see, health care workers are also coming in second in terms of performing FGM, and also the traditional cutter, and we are seeing an increasing role of healthcare workers performing the traditional cutter, performing also medicalized FGM through using the health supplies. Allow me to go directly and talk about some of the quotes coming from the community, and this to say that what we are seeing is that there's less severe type of FGM, which now I have mentioned being Kisasa, which is performed by both traditional cutters and healthcare workers using hospital supplies. And also we are seeing that both medicalization and the Kisasa types of FGM are locally being referred to either as Kiswahili or Kisasa. And we would be asking ourselves, why are they performing this Kisasa or Kiswahili? And it's basically to minimize the health complications, perpetuate the culture, and evade the law. And it's being performed secretary at home, both in the private health facilities as well as at home. And then if I can just quickly share a quote to show that medicalization of FGM is happening. This is from a survivor of medicalized FGM, where she said that the type of FGM performed nowadays is called Kiswahili, where only the clitoris is cut. Medicalization is also happening because when I got pregnant, when still in high school, I was taken to the health facility to deliver. That's when the cut was performed on me without my knowledge. And some of the drivers of medicalized FGM is the biggest one is income. It's an income to the health to the practitioners performing FGM, and we could see that it's averagely around Kenya shillings 15,000 to perform medicalized FGM. Another driver of medicalized FGM is that they are circumventing the law, and also teenage pregnancies. The fact that you are not allowed to give birth if you have not been cut, then it means you'll be cut during the delivery, as shared from the previous quote. And also them saying that it promotes faster healing, and therefore a girl is able to go back to school within even a week. And then in terms of complications, I want to make it here clear that still medicalized FGM or Kisasa type of FGM also have the immediate physical complications, sexual complications, psychological complications, birth complications, as much as it's being considered as a safer form of of FGM. And then if I could go directly to the role of health professionals in ending medicalized FGM, the first thing that I want to put here is that there is need for a multi-stakeholder collaboration to address access of medical supplies to the traditional katas that promote Kisasa FGM, as I had shared earlier, that even the traditional katas are performing medicalized FGM using the health supply. So there's need for a multi-stakeholder, multi-sectorial, collaboration to address access of medical supplies. And also another key recommendation, especially on the role of health professionals, is that there's need for surveillance and monitoring of private practitioners and the clinic activities and taking action on those who perform FGM. Finally, something else that I would also want to highlight here is that there's need for sensitization of health workers on human rights around FGM and the do no harm principles, that whether medicalized or not, it still remains a human rights violation. In conclusion, what are we saying is that interventions, the current interventions also need to shift and have a special focus to the chemists, their pharmacists, for their role in selling health products, equipment, and supplies that are key in sustaining medicalized FGM. Also, there is need to strengthen the health systems in monitoring and surveillance of systems to identify cases of FGM, including medicalized FGM. So this is the report that we did. It's available on our website. It's called No Justification, Medicalization of Female Genital Mutilation in Maasai Community, a case of Narok County. It's available on our website. I'll be putting in the link on the chat box, but also you can download it under the research work. Thank you so much.
Thank you so much, Frida. Thank you very much for that presentation and to the point. What's extremely valuable about what you're sharing is that you're sharing with us the research and therefore the evidence from a community, but that reiterates for us again that there is increasing medicalization, or where it's not increasing, there is sustained medicalization of this practice. And that the other, I think, also really valuable insight you've provided by the naming or how it is named in the communities that you were studying is that it also seems to suggest to us that there is possibly a renaming of this practice. And the question might be, is this another way in which the practice becomes invisible, right? Because it is no longer understood for what it was. Because as long as we keep seeing the sort of renaming. It's not just happening in the community you're speaking of, but we're seeing it also in other communities where we have efforts. And we ask ourselves, what does this mean with regards to the kinds of interventions we need to do? But also, do we actually know what it means? Do we actually know what it looks like? Do we actually know whether there actually is a change or is simply the same, but now just renamed to make it invisible? And also, critically, you're also sharing with us the continuing critical importance of addressing the medicalization and now even more so the uptake of this work by traditional birth attendants. So thank you very much for sharing that. So I'd like to open it for comments and questions. So Anne, I will need your help here. There may be comments and questions in the chat that we can bring forward and open or share. Thank you, Anne.
All right, thank you so much, Dr. Jacinta. Yes, we have quite a bit of engagement on the chat. Izioma is asking, did I hear reducing the age of cutting from your presentation? I think she's referring to Frida's presentation. And then we also have Eric saying, happy to hear Mrs. Lolojo Bernadette as the CEO of Anti-FGM. She inspires us as young people from Samburu County. She's our role model and mentor. She speaks little but acts a lot. Her efforts for Kisima Declaration has really promoted the eradication of FGM. So thank you for that comment. And then we have Julia saying, good presentation, Madam CEO. We also have Eric saying again, the focus on culture and religion by understanding It will provide more insight as to how to eradicate FGM. And he says that he concurs with Dr. Muna. Then we have Dr. Eric again saying, I agree with Muna on curriculum where we create awareness on facts about ending FGM. And then Adam says, thank you, Dr. Muna, for this information. The difficulties you're having in Somalia are exactly similar to the ones we experience in northern and upper eastern parts of Kenya. That's Adam. And then but Madam Loloju has said that when you visit the Anti-FGM Board website, you can be able to download some manuals from there. Ezioma says, Ngina, you are already an advocate, and congratulations for sharing. And then we have Ali, who says that he or she is an orthopedic trauma technician currently in Garissa County. And we have a question here, which I think we can answer towards the end, which asks, and is still Ali asking, I'm an orthopedic trauma technician. How is my professional able to help fight FGM? Because this is my first time attending this meeting. So thank you that we have someone who's hearing this for the first time. We'll be able to answer that towards the end. But we have Ezioma who is asking, what is the difference between traditional kata and TBA? And I think we can pass this on to Frida, who has done the study, because I think this comes from your study. And then after here, Dr. Jacinta, we can come back to the panel.
Thank you very much, Anne, for highlighting those comments and questions in the chat box. So please continue to provide those questions and comments in the chat. So Frida, if you could very briefly answer that question around the distinction between traditional katas.
In terms of traditional katas, they are the ones who are known to perform FGM. So they only have one role, which is performing FGM. But we find that the TBAs, the traditional birth attendants, whose role initially and traditionally was to assist pregnant women to deliver. But now we are also seeing and increasingly them taking up the role of performing FGM. So the difference is that the traditional kata is purely does the work of performing FGM, but the TBA has multiple roles in the community, but now she's also taking up other roles of performing FGM. But in this case, they are also using the health supplies to perform the Kisasa type or the medicalized FGM.
Thank you very much, Frida. I think that was clear. Thank you. So if I can now move to the next panelist, allow me to invite Professor Samuel Kimani, who's a health expert, researcher, and an associate professor at the Faculty of Health, University of Nairobi, and the Africa Center for Abandonment of Female Genital Mutilation Cutting, known as ARCAV. So having listened to the new findings of COWAB, Professor Kimani, I have a couple of questions for you. And the first one is, ARCAV has developed an End FGMC training curriculum for medical students. How did ARCAV determine the learning objectives and goals, given what you've heard so far, also from Somaliland as well as from Kenya?
Thank you, Jacinta. Am I audible?
You're very audible. Go ahead.
Very well. Thank you, Dr. Jacinta, and thank you for the participant. And we are happy that we are having this forum this day. Straight on to what we do as ARCAV, and I said ARCAV is affiliated with the University of Nairobi. So what that means is we have a constituency of training medical trainees, medical doctor trainees, nurses and midwives, as well as pharmacists and dentists. So for this program, implementing the ARM program, we targeted the health trainees who, once they qualify, they are going to be interacting with women and girls, especially when they are seeking reproductive health services. And the most important ones will be the medical doctors, the clinical officers, nurses, and midwives. So that was our agenda. And I'm happy that now, with the evidence that we are already receiving from COVO, it appears like we need to change tact. And the tact here would be we need to widen our constituency to include the pharmacists, because they are the ones who are supplying the pharmaceuticals and other health supplies that are used in medicalization. So to come straight to your question, Dr. Jacinta, I would want to say that this was a very stakeholder-rich engagement. So we know that for anything to be taken in form of a program, then you need to engage the stakeholders. So one of the things that we did is to make sure that how can we engage stakeholders? We went ahead to do mapping, and this mapping involved making sure that we identify all the institutions that are training the healthcare providers, both at the university level and also at the middle level colleges in Kenya and in the other 4 countries, Senegal, Somaliland, as well as Ethiopia. So after we did the mapping, the second thing we did was to carry out what we call needs assessment. And the needs assessment here was we developed a checklist, and this checklist would have questions, and some of the questions would be, can the lecturers who teach these health trainees be able to tell us what is contained in the curriculum in terms of ending FGM? So we had a checklist, and that is what we send to the lecturers and the different organizations for them to fill. So we did this through the email, and in some geographies, for example, in Somaliland and Ethiopia and Senegal, we were able to sit with the stakeholder once we call them to the meeting, and they will fill these forms, and we'll take that and analyze the data. Once we analyze the data, we'll come back and have a meeting with a meeting with the stakeholders. We'll tell them this is what we have found in your curriculum. These are the feedback that you have given unto us, and then we'll agree how then can we be able to best implement this program in the universities and colleges. So in a nutshell, that is what we do. And although over and above that, we also undertook a desk review. And this desk review, we were able to bring on whatever the different components from the best practices, and we draw our best practices from organizations like World Health Organization, where the WHO has been able to develop the what we call the handbook, clinical handbook for healthcare providers. It has the training manual. And it has personal-centered communication tools that are very key when you are addressing issues to do with women reproductive health around and issues to do with FGM. And even for us to make even this to be contextual specific, for example, in Kenya, we already had a manual that was developed in 2007. Of course, we recognize the manual was a bit outdated, but it also offered a good foundation for us to develop the curriculum. And finally, of course, we had generated quite a substantial evidence that there was a major gap in the skills and knowledge among healthcare providers in a study we conducted in Kenya in 2018. And this study has been published about health systems response to FGM prevention and response. So that is how we underwent developing our learning objectives and goals. Thank you, Jacinta. Over to you.
Thank you very much, Professor Kimani. So my next follow-up question to that is, what kind of feedback has ACAV received from educators and learners using this curriculum?
Thank you, Dr. Jacinta. Now, one of the things from the word go is it is true that there is some integration in the colleges and university health programs, that we actually found that there are some component in regard to FGM. Mm-hmm. The problem with that component is that it was variable. For example, you'll actually find that in some universities or even colleges, the teaching will only take about 30 minutes. Some institution will teach for 4 hours. And for us, what we we analyzed from there, and the conclusion we made from that, we actually thought that the teaching and the integration that is happening in the universities which train healthcare providers was one, it was inadequate in terms of duration of teaching. Number two, it was not structured. Number three, even the trainers themselves actually said they have never gone through a formal training. So they were applying their skills and knowledges that they generated from their professional training during undergraduate. And therefore, we thought that this was a big gap. So, however, we did get very interesting feedback. Some of the feedback, especially after the training, is that our curriculum, the one that we are implementing, was able to impart very new knowledge. One of them is it showcased the burden of FGM globally, regionally, as well as specific geography. For example, when you talk about Kenya, we could even display this FGM burden depending on ethnicity and geography, including counties, stuff like that. The second thing was the issue of medicalization was actually a shocker to some of the trainees, including the faculty members. They couldn't understand how healthcare providers were involved in cutting. But of course, the data, especially the data from the area of the county of Kisii, Garissa, Nairobi, that was a shocker. And then issues to do with the rigor and the human rights approach to addressing FGM. This is something that was not addressed anywhere before. But this is our curriculum is actually rich in that. The other thing is, of course, one of the things and the gold standard when it comes to birth complications, and you've heard that FGM is associated with birth complication, especially the type 3 FGM. The women suffer from complications like obstructed labor. So the trainees and the faculty members were happy to have received training and skills on how to perform de-infibulation. And this is something that is life-saving. Once you do de-infibulation, we know it improves on the birth outcome, it improves on the sexual outcome as well as other physical outcomes. And the trainees were very happy about that. The fourth thing that was very critical is the feedback that the training actually reminded and reinforced the importance of professional as well as ethical principles, especially among the healthcare providers, especially on issues to do with do no harm, but also addressing medicalization. And then the other important thing is the trainees were actually able to appreciate that FGM is associated with psychosocial and sexual complications. And we were able to take them through on how they can be able to intervene on sexual and psychological complications. Remember, in the 2018 study that we did in West Pokot, one of the issues that came out is a lot of women presented to them to the health facility with sexual and psychosocial complications. But the healthcare said there's nothing we could do because we don't have skills on what to do. And we thought this was a real gap that we needed to intervene. The other thing is, of course, the trainees, including the faculty members, said they would want to be linked with the CSOs and also champions who are working in the community so that they can be able to help in the prevention of FGM, including medicalization. And the last bit, of course, is which is pertinent to the training, is that a lot of there was a lot of confidence in the training. So people, the trainees were able to acquire confidence in the way they could address some of these harmful practices. But finally, of course, it stimulated desire for research, especially in the universities. So we started to hear that students are really yearning to develop protocols that can be able to understand how FGM is happening in different geographies. So in a nutshell, that is what those are some of the feedback we received.
Thank you very much, Professor Kimani. I think what you've shared just highlights the incredible value of the curriculum you'll have developed, the efforts you'll have taken with regards to building the capacities of both pre-service and in-service providers. So there's enormous value in making sure that this integration work, which is integration of FGMC into the health sector, becomes understood, that your work can be and will be replicated because of the lessons you're drawing from the efforts you've undertaken in Kenya. And I know, just to share with everybody else on this call, these efforts, guided very much by ARCAV, are being moved into our other regions of work in Somaliland, Ethiopia, as well as Senegal. So thank you very much for those inputs, Professor Kimani. I would like now to actually invite Rosalind. We weren't able to reach her earlier. She's now on the call. Rosalind Guyo is a dedicated nursing officer and a survivor of FGM. And she stands at the forefront of change in Isiolo as a founder of Waso Hope community-based organizations. So, Rosalind, I'd like to invite you with the following two questions. The first question: why do women and girls who have undergone FGMC sometimes hesitate to seek medical attention when confronted with health issues? That's my first question.
Hello, everyone. My name has been mentioned, Rosalind Golo. I am the survivor of FGM, a CEO of Waso Hope, and awardee of the president, as Jacinta mentioned. And I'm privileged to be here today, and I think you hear me properly. Survivor of FGM. The first question about the experience. Women face social cultural barrier while seeking particularly cultural taboos against discussing matters related to the sexual health with male clinicians. Most of the time in our own tribe, that is Borana tribe, because my tribe is Boran, they really fear discussing their own issue with a male clinician, and it happened that if it were female, they would have been more open. Women endure fear, and that is what we call phobia of clinician, that they can disclose the status of their condition to relative and even the guidance. In African setting, women do not disclose personal matters, especially concerning their private and reproductive part, since they are termed as a lesser woman if abnormalities are discovered. In most of the religion, that is especially in Muslim religion and the culture setup, women were forced to suppress their feelings, emotions, agonies out of properties. The permanent scars, e.g. the keloids, their sexual reproductive part, make them hesitate to display their bodies to the clinician. Due to some fistulas which are developed due to the cutting, girls and women end up being abandoned by multiple partners. The shame and the stigma from this make them unwilling to share their stories. This lack of the society support, especially the partners, also make them unable to access medical care. That is what I have answered in the first question, Jacinta.
Thank you very much for sharing that. So my second and very related question is, as a nurse and a survivor of FGMC, how can healthcare professionals better address the unique challenges faced by survivors of FGMC within medical settings?
That's a very good question. And actually, I really appreciate being a medical personnel, at the same time being a nurse survivor. The healthcare provider should be informed about the society, tradition, and the religion background, and the clients on their religious practices. Healthcare provider should add FGM survivors' history to the questionnaire in the MCH, FP, maternity registers, theater, and even the pediatric registers as an entry point required for all the survivors to be acknowledged. Healthcare provider should be trained on the myth and misconception which is surrounding female genital mutilation, its risk, and especially on reproductive health of a woman, on the psychological impact of a woman, because women feel so down and there is a lot of psychological trauma during the cuts and even after the cut. The long and short-term medical complication during the fistula development and the delivery should be well elaborated and being discussed in the syllabus or even the models which will be produced by the medical part. On the education, socio-economical discrimination and wellness of all women should be tackled by giving them the therapy on emotional well-being. Healthcare providers should be given capacity building on the 4 types of female genital mutilation, because there are many who even don't know the type of female genital mutilation. Healthcare providers should be brought or taught on the trends in Kenya and the 5 tribes which are practicing, especially the Luo, Luya, Teso, Turkana, and the Pokomo, who are not practicing. Many of healthcare workers are not aware. It is only 22 hotspot county that we are facing, and there is emerging trend which is coming up in medicalization. Healthcare provider should be equipped with knowledge on survivors and the way they face what they face during the cut. Healthcare provider should be using accommodative language. Survivors are very sensitive. Issues of female genital mutilation are very sensitive, and therefore healthcare providers should be taught on do no harms policies and how to go about it. Thank you, Jacinta.
Thank you very much, Rosalind. You've done 2 really critical, you've provided us with 2 critical inputs into our discussions today. One, you're highlighting the very unique barriers that women face, and the key word here, unique barriers that women face in accessing medical care, which from there suggests that as we do our work with involving and integrating into the health sector, we have to give really critical thought to the kind of very specialized skills that will be needed. There's not just going to be enough that we are bringing attention to the medical and psychological consequences of FGMC, but that we're also aware that to address those issues successfully for women, that critical skills are needed in order to have women actually feel that their challenges have been fully addressed. So thank you for bringing attention to the need for having not just medical skills, but really specialized skills when addressing the needs of women. Thank you. I would like now to invite Cristina Polito, a scientist in the Department of Sexual and Reproductive Health and Research at WHO in Geneva, where she leads the work on harmful practices, including FGM, developing, testing, and integrating evidence-based approaches to strengthen health systems while promoting gender equality and rights. She has more than 2 decades of experience in research and programming on gender-based violence, FGM, and reproductive health. She has a PhD in public health from Johns Hopkins University. A welcome to you, Cristina. I have 2 questions for you. The first one, how does WHO support the global health sector in preventing and responding to FGMC?
Thank you so much, Jacinta, and to all the panelists. I have to say it really makes me happy to hear a topic of a webinar on the involvement of the health sector, because this is something that is really important to us, and this is something that we've been working strongly to try to bring into the multi-sectoral approach on FGM prevention and care. WHO does this in a number of ways, and first, to start, we develop evidence-based resources. And some of these have already been mentioned in some of the previous interventions, but I want to highlight a few of these because these are resources that are global public health goods, and these are available to countries to use, to contextualize, and to implement in terms of integrating FGM prevention and care content into the curricula, whether that's pre-service curricula, as we heard, or if it's in-service curricula. So to highlight a few of these, one that we are really excited about, and I know some people are already using, is our person-centered communication for FGM prevention training package. So this is based on the fact that women come into primary care level. Most of the health care in FGM prevalent countries is provided at primary care level. And most of this is provided by nurses and midwives, in fact. So bringing them in as opinion leaders, bringing them the skills that they need to communicate on FGM prevention, not just on the complications of FGM, which I'll get to in just a moment, but to make sure that they know how to communicate effectively in a non-judgmental manner, in a way that's supportive of women, that's person-centered, that's woman-centered, is absolutely critical in this whole conversation. So we developed a guide to support the nurses and midwives in particular, but it can be used for other health workers as well, to learn how to communicate effectively in this way. We've developed a set of steps that walks through how they can provide these services, assessing where women are. We call them the ABCD steps, assessing where women are, discussing her beliefs, communicating for change, and then discussing and deciding. And first, we work with the health providers to train them and to work with them about their own values and what values they may bring, what attitudes they may bring. Because as we know, there is medicalization. And we also know that a lot of health workers are supportive of FGM. They come from the same communities where FGM is practiced, and they may also support. So this step first of really working and unpacking this kind of beliefs is a first step in this training process. The training also discusses laws and policies in the country, discusses the beliefs, and it teaches these skills, and it supports the health workers and gives role-playing exercises on how to do this. So this is really important, and this is a important contribution in recognizing that any multi-sectoral approach needs to involve the health sector, needs to involve the primary care health workers in particular. We also have the clinical handbook. A lot of you are familiar with this. This has chapters on each of the different types of health complications, including the mental health complications, including the sexual health complications as well. We have guidelines and other resources as well. We're currently in the process of updating our guidelines too. We also have a tool. I can put some of these in the chat after I'm done speaking, but we have another resource, which is how to integrate FGM content into the curricula of nurses and midwives. And this is a step-by-step guide. It's not giving the content. We refer to the content from other resources and talk about how we can do this in a way that ensures integration in the future, because ultimately what we need is to make sure that the content on FGM prevention and care is integrated into the pre-service curricula. In the meantime, we can reach those who are practicing, but ultimately if we can integrate, that is the most sustainable approach, it's the most cost-effective approach, and that's definitely the way forward, and that's what we need to work with countries. So in terms of the resources, that's a big area we're working in. We also are supporting countries to implement these resources. And there is this global strategy against the medicalization of FGM, which we work with countries to implement. It has 4 pillars of activities, and these include building political will and finance, making sure there's adequate budget lines for implementing programs, training of health workers, and some of that we've discussed already. There's the aspect that relates to accountability mechanisms. So what happens if a health worker does perform FGM? Are there any consequences? What is the accountability around that? And then how can we monitor and evaluate that? And then the third big area of work that we're doing is around generating evidence. And some of that is compiling evidence around the health burden, costs, around what works to end FGM. It's supporting the generation of evidence. And also we do primary research as well. For example, we tested this whole person-centered approach, and we were really fortunate to have Kenya be one of the countries where that was tested in a cluster randomized trial where we worked with public health clinics in communities where FGM was highly prevalent. So there's a number of ways, and the key thing too, I just want to say, is that we really need to work together with other sectors and recognize that we each have our role to play, and that the health sector is really a critical part of this. And I'm so glad that you're organizing this webinar, and I look forward to continuing the discussion with other people too on some of these particular areas and resources. Thanks, Jacinta.
Thank you, Christina. So my second question, drawing on what you've just shared, is what are some of the key lessons, successes, and challenges that WHO has experienced in engaging ministries of health in different countries towards FGMC prevention and response? Given you've just highlighted how key it's going to be to integrate into this health sector as well as other sectors.
Yeah, okay, let me start with the challenges first so I can end with a more positive lesson learned. In terms of challenges, I would say that FGM is, in context where we're seeing more and more humanitarian crises. We're seeing conflicts, we're seeing, climate, climate change issues and other types of humanitarian disasters and crises. And these are really makes it difficult to keep FGM as a priority. So what I think that really also leads to the importance of integration, because if we can integrate FGM content into sexual reproductive health programming and make sure it's there as part of essential packages of services, whether those are in emergency settings and humanitarian settings, then we can ensure that health workers and the next generation are being trained in this way. We have another challenge has been we have not seen the health sector as one of the key actors in the space. And again, this webinar, I think, highlights the importance of that. And that has meant that there has not been adequate funding to really implement some of these programs. And FGM has not been integrated into the curriculum. Even in countries where, the majority of women have undergone FGM, health workers receive little to no training, as we've heard from some of the health workers here themselves and some of the students. I think these are really big challenges. I would say, some of the lessons we've learned is really making sure that we have this comprehensive approach, which is on both the prevention and the management of complications. So with any public health issue, we can't just say treat the complications. We have to simultaneously work to prevent the practice in the first place. And we need to make sure we have linkages across sectors, that we have strong multi-sectoral actions. And I think more, we're seeing some positive examples of that. This person-centered approach is another lesson that we've learned, which is highly effective. And it's also really important that we keep the woman at the center of the decision-making and at the center of, the care that's given, and listen to her and understand where she is. And if we want to work with a woman to try to prevent FGM in the next generation with her children, then it's absolutely important that we're listening to her and knowing where she is and, understanding, and that the health worker has the skills to have those conversations and really support her, the psychosocial support, and making sure that the health workers also understand the psychosocial and the sexual health complications that they can help to manage as well. And that this can be part of health systems strengthening work more broadly. And I think this is where this global strategy against the medicalization comes in, is really is a health system strengthening approach. And that's absolutely critical in ensuring that the care is delivered at the primary care level. And we can also work with specialists, OBGYNs and other specialists. But what we really need to make sure is that the frontline health workers who are working at primary care level, who are in the communities, part of the communities where FGM is practiced, are really part of the conversation and have the skills and have the resources to do the work that they need to do. So I'll leave it there and just thank you again, Jacinta, for this opportunity.
Yes, thank you very much, Christina, for sharing that. And we'll open it in a few minutes for discussion. Excellent, excellent. So let me take this moment to invite and a very warm welcome to you, Dr. Isaac Bashir. He's the Acting Director, Directorate of Family Health at the Ministry of Health in Kenya. He has been entrusted with the expansive role of overseeing the Directorate of Family Health, managing a range of vital divisions encompassing maternal and reproductive health, child health, community health services, mental health, and tobacco control. Dr. Bashir has a long-standing career in the medical field, having begun his medical journey at Hacettepe, I don't know if I pronounced that correctly, University in Turkey in the 90s. So a very warm welcome to you, Dr. Bashir, and thank you for joining us.
Thank you, Jacinta. Yes, my name is Dr. Bashir Isaac, and I'm glad to be here. I have been in this journey earlier in my career, and I've been in this space for the last 24 years. And I started the FGM activity from Mandera, where there is 99% of the population are still practicing, and I'm a member of the anti-FGM board in the country. And was part of this journey anyway for quite a while. So allow me to really be formal now and start my keynote speech. FGM is a harmful practice that violates the human rights of the girls and women and has serious health consequences such as bleeding, infection, infertility, obstetric complications, and all the rest. Just to mention that I'm also an obstetrician and gynecologist, and therefore have seen this thing firsthand and deal with it on daily basis. Kenya continues to make tremendous efforts to end FGM, with the prevalence of FGM having declined from 38% in 1998 to 15% in 2022. Since 2014, the percentage of circumcised women who were cut and had flesh removed declined from 87 to 70%. And in the ICPD 25, our former president, committed to eradication of FGM by 2022. We are yet to see that. We are post 2022. But the agenda of FGM, medicalization FGM, is a very serious agenda in this country. Strengthening referral and coordination systems through skillful engagement of the community to the health facility and rehabilitation back into the community continues to be a critical component in curbing the practice of FGM. As we join the world in commemorating the 16 days of activism against gender-based violence, the Ministry of Health continues to embrace collaboration in healthcare through innovation, surveillance, and prevention, cutting across all forms of GBV and precisely female genital mutilation. Medicalization of FGMC is a dangerous development that hinders efforts to abandon the practice, as it gives a false sense of safety and legitimacy to FGMC and undermines the role of health providers as advocates for health and rights of girls and women. The health sector has a vital role to play in preventing and responding to FGM by providing quality and respectful care to girls and women who have undergone FGM or are at risk of the same. Through personal-centered communication, healthcare workers have better capacity to act as change agents and also engage communities by educating and empowering them and their families to reject and turn down the practice. We have partnered with key line ministries, other sectors and stakeholders such as education, social services, judiciary, the media, the religious group, community leaders, civil society organizations, and the anti-FGM board to have interventions on ending the medicalization of FGM. And this includes, from the Ministry of Health, engaging the different regulators of healthcare workers and their associations in creating awareness and concern on medicalization of FGM, e.g. the Nursing Council of Kenya, the Kenya Clinical Officers Council, the Kenya Medical Practitioners and Dentists Council, Kenya Obstetrics and Gynecologists Council, and other associations. They all confirm that no training curriculum teaches healthcare workers to perform medicalization, and they uphold the do no harm principle. Any healthcare worker found performing FGM will face the full force of the law and risks being deregistered. We also developed a training manual for the healthcare providers in Kenya on the prevention and management of FGM health complications. The goal of this training guideline is to build the competence of participants to provide comprehensive quality services in the prevention, identification, and management of complications. We also included the person-centered communication in the training manual on prevention and management of FGM. The reporting tools that capture if FGM is medicalized. This helps to plan for interventions as well as identification and addressing the gaps and challenges in the health sector. We've rolled out universal health coverage and primary healthcare networks, which ensures the health and well-being of all from the community level, leaving no one behind. That's our main agenda of the president, the current president, and the current government is the UHC and primary, based on a platform of primary healthcare. And where now we have employed over 100,000 community health promoters, and we need to bring them on board as Minister of Health, educate them so that they can stay in the society and provide more health education on FGM. Kenya has made available the National Legal Framework, Policies on Eradication of Medicalized FGM, which advocates for eliminating FGM and its medicalization, while guiding healthcare workers on interventions to end the cut. The National Policy on Eradication of FGM 2019 identifies the key issues affecting elimination of FGM and proposes high-impact strategies to address the FGM in key sectors, including the health sector. Female genital mutilation and its medicalization is a crime in Kenya. The law Prohibition of Female Genital Mutilation Act number 32 of 2011 states the same. And with all the subsections, section 21 provides for disciplinary proceedings against medical practitioner who commits an offense under the penal code or commits a disgraceful conduct in a professional respect. Section 25 provides for disciplinary actions against a clinical officer for dishonoring the profession in the public estimation or has been guilty of negligence or malpractice of this profession or impropriety of misconduct, whether in respect to his profession or not. Section 18A provides instances where a nurse may be removed from the register if found guilty of misconduct by the Nursing Council of Kenya. This year's 16 days of activism against gender-based violence is running under the theme Unite, Invest to Prevent Violence Against Women and Girls. This is a wake-up call to all health practitioners at all levels in rural and urban Kenya to firm our commitments to ending FGM. Let's all unite and speak up against zero tolerance for FGM. And globally, I've been 2 months ago, I was in Egypt on discussing ending medicalization of FGM. And I believe the major threat to eradicating FGM is the medicalization component of this. And we intend to have a conference on the same in the country in a few months to come. With those few remarks, I want to say thank you, and I'm open to any questions or discussions that you may have. Thank you.
Thank you very much, Dr. Bashir. What will also be your opening remarks make for very nice closing remarks, in fact. So what I want to do is open the floor for a few minutes to any comments or reflections, and I'm handing over to Anne to manage that.
Thank you. Thank you so much, Dr. Jacinta. We have a question from Joy, who is a university student and is asking, and I would like to direct this to Dr. Kimani first and also to Madame Loloju. So we have medical students who are saying, how then can they continue to be part of advocating for end FGM once they integrated back into now being, how can they continue with advocating against FGM? Dr. Kimani briefly, and then Madame Loloju, because I also know Madame Loloju works a lot with the youth. Thanks.
Yeah, thank you, Anne, for that question. And for us, I think it is a continuous work. So one of the agenda we had started with the medical students in the universities and colleges. We have a plan to expand this to the non-medical college students. And I think that will be one of the ways we can be able to make sure that we create a movement within the higher education system so that they can be champions against FGM. But of course, even for the health trainees who qualify after, there are platforms where they can continue to advocate this. And one of them is through the conferences and workshops and continuous professional development meetings that can happen in hospitals or maybe within what we call the professional forums. And we particularly want to engage the midwives. That is something that we have already started. We have continued to engage the nurses and also the Kenya Obstetric and Gynecological Society meetings. We have situations where we showcase the issues of medicalization and how to respond to women with the complications. That is what I would do. And the final bit, of course, is I really want to thank Dr. Bashir for coming in, and especially the new agenda for universal healthcare, where we think that working through the community promoters, this is going to be really pertinent, especially in addressing medical issues to do with medicalization and FGM at the community level. Thank you very much.
Thank you, Dr. Kimani. Madam Dolojo, if you can also pick up the answer to the question around how can the youth, especially the young doctors, how can they continue with advocating once they leave school against FGM?
Yeah, number one, we need to, government will always be there. So the anti-FGM board will always be there. So for sustainability purposes, it's important for the University of Nairobi through ACAF to collaborate with the anti-FGM board directly on this issue of the training. We need to partner together with the ACAF and see how we can bring those who have already been trained, as I had said earlier, or through the messaging platform, that we need to have the medical doctors or the medical students become TOTs, because most of them will be released to the counties. How do we also take this curriculum to the counties, even through the universal healthcare, and also bringing the community healthcare workers? They're called health promoters into this, because they're the people at the community level. They have to be trained. So I think this is something we need to follow up with ACAF and also with the generation equality, that's options, to see where areas of collaboration, and because we need funding, a lot of money is needed into this. And then we can see how the ones who have already been trained, I hope they've already formed WhatsApp groups where they can be discussing. Today I'm in Narok, we were with we were with the KNBS team. We were here to share the results of the KDHS results with the county teams, and we feel that the county is ready to pick up the work that we are already doing at national level, so that they can also continue, because they are the ones on the ground. Yeah, so I think that's an area we can still follow up after this and see how we can partner and come together.
Thank you. Thank you so much, Madam Doloju. So to the young doctors, Joy, please form WhatsApp groups. Invite us. We can always link you back to the anti-FGM board. We have a question from Diasi, who is asking, where does the medicalization of FGM take place, in public or private hospitals? And I want to pass this on to Frida from Covao, who has done the research around medicalization. So the question is, does it happen in public hospitals or in private hospitals? Where is medicalization carried?
Thank you so much, Anne. So, according to our research, we found that medicalization of FGM is mostly happening in private hospitals, but also it's happening at homes where the family is asking mostly the nurse to come at home and perform FGM. So, but mostly it's being done in private hospitals, especially when the mother is giving birth.
Okay, thank you so much. I read a comment from Dagem. I think this is someone from Ethiopia, who is saying the implementation of the Ethiopian national curriculum has been a vital tool in our efforts to combat FGM. We have worked closely with local stakeholders, including teachers, community leaders, and parents, to ensure the effective dissemination of this curriculum. And then he goes on to say, in addition to classroom-based activities, we have engaged with parents and community members to address misconceptions and also dispel myths surrounding FGM. We have a question for Dr. Kimani. What is the key role of level 1 health facilities in integrating FGMC prevention in healthcare? Dr. Kimani, did you hear the question?
Yes, Dr. Anne, I think that question has been almost answered with the speech from Dr. Bashir. And of course, I can emphasize that. I think this is where, and of course, Dr. Parito also said from WHO, this is where the battle will be won, because level 1 and 2 are the ones that majorly interface with the girls who are at risk of FGM and women who have been cut. They, of course, through the level 1, then we can have the community health volunteers, the community promoters working through, and they can work. That is also where they interface with the health system. So this is very key. So, and for us, I think the target, of course, one of it being that these level 1 and 2 are managed by nurses and clinical officers, who are the majority of the trainees who come from our colleges and the universities. So what we did, initially our target was to target universities, but we realized professionals from the universities are basically take care of around 20%. 80% of the graduates and professionals actually come from medical training colleges. So we already have working with the medical training colleges to make sure that FGM is incorporated into their curriculum. But we have a gap. I think we have not addressed the certificate trainees in the colleges, who are not very many. So we are actually purposing to do that. And of course, for the community health volunteers, our colleagues, AMREF, they are very strategically powerful in that area. We are working together to see, can they be able to make a kind of adopted or maybe scaled down curriculum so that can be used to train the community promoters and maybe engage communities for a good reason, for surveillance, and also these community health workers. You don't also want them to convert to be the cutters, because that is one of the other risks we run, especially in counties where they don't receive stipends. So those are some of the things that we are thinking moving forward. Thank you.
Thank you so much. One last comment here, and it's to you again, Dr. Kimani. So there's a question here from Talaso Barako, who says, which curriculum incorporate teaching on FGMC, degree or diploma? Is it likely a short course level? Would be great to update our curriculum with research, and also involvement of HCP at grassroots, updates and advocacy by the same. So Dr. Kimani, in terms of the curriculum, does it target diploma going up, or is it degree? You can explain that to Barack.
Yes, sorry. It actually targets both degree trainees and also diploma trainees. So what we have not done is to target the certificate holders, but that is something we can easily do for trainees who are in the universities and colleges. Now, for the ones who are already working and they may need to update their knowledge, the Ministry of Health is already doing that. Of course, we did support them to develop that, of course, through the support from World Health Organization. So for us, we think that completing that cycle is key. So the only gap now that is remaining is for the health promoters. If we develop a curriculum for them, then we are good to have completed the cycle of making sure that everybody who works in the system is well capacitated and empowered. Thank you.
Thank you so much. Before I hand this back to Jacinta, we have a poll that is running just to gauge how this discussion has gone. So if you can create a minute or so before you leave, we'll be happy to receive your feedback, because this will enable us to know how best to curate the next webinars or the next discussions. Jacinta, thank you, and this is back to you.
Thank you very much, Anne. And thank you, everybody, ladies and gentlemen, because we've now come to the end of this discussion. And I want to thank all of you for joining us and engaging with us. And there is never really enough time on this. But I want to conclude by saying, I think what this webinar has highlighted the very critical role that the health sector will play, not only in prevention, but also in responding to the needs of survivors. And always this work and these efforts supported, highlighting the dignity and human rights of girls and women. That has been clear throughout. And I also want to highlight here that the key institutions that are leading this work, and also supporting efforts for all of us, have been ACAV as well as WHO. And they're working towards strengthening that sector, not only with skills, but also with evidence and also with resources. But also, I think what is critical that has been highlighted by the very fact that we've had Madam Bernadette on this call and Dr. Bashir on this call, is that this work is not possible if we're not collaborating with governments, because it is with governments that we can sustain these efforts. It's also working with governments that we can also ensure that our reach is wide and deep to where it needs to be and go to. So the recording will be edited and will be shared with all of you at a later date. And so thank you, a very good morning to some of you, and a good evening to the rest of you. So, or wherever you're joining us from. So thank you very much and have a very wonderful evening or day that is beginning. Thank you. Back to you, Anne.
Thank you so much. So the poll will show up in your page when the call is concluded. Please take a minute to give us your feedback. We'll be happy to see how we can continue with these very crucial conversations. That said, I want to say thank you and goodbye. And let's catch up as time goes by in the new year that is coming up. Thank you.
Thank you, everyone.
Thank you.